Here we have a 27-year-old woman that presents with fatigue, dizziness, and shortness of breath on exertion. Let's walk through exactly how you'll see this on the boards, step by step, revealing clues as we go along. The patient reports 3 weeks of progressive fatigue. She describes feeling lightheaded when standing and notes shortness of breath when climbing stairs, something she previously never experienced. She denies chest pain, palpitations, fever, cough, or recent illness. Her last menstrual period was 2 weeks ago, and she notes her periods are heavier than normal over the past 6 months. On examination, the patient appears pale, but in no acute distress. Her blood pressure is 104/62, her heart rate is 102, her respiratory rate is 18, and her temperature is normal. Her cardiopulmonary exam is also normal. There is no murmurs, no crackles, or wheezing, but conjunctival pallor is noted. Her abdomen is soft, non-tender, and no hepatosplenomegaly. Based on the initial findings, what is the most appropriate initial laboratory test? Should we get a complete blood count, iron studies, a pregnancy test, thyroid function tests? Her hemoglobin is 7.9 grams per deciliter. Her hematocrit is 25%. Her MCV is 72, and her RDW is elevated. White blood cells and platelets are normal, and the iron studies show that her ferritin is low, her serum iron is also low, and her TIBC is high. All of this tells us that we are dealing with a microcytic anemia with iron deficiency pattern. When I think about anemia, this chart immediately comes to mind. It's one I truly believe is worth memorizing. Anemia is broadly categorized into microcytic, normocytic, and macrocytic types. This patient falls into the microcytic category because the MCV is low. Microcytic anemia is most often due to iron deficiency, which limits hemoglobin production and commonly results from chronic blood loss, like heavy menstrual bleeding, poor dietary intake, or malabsorption. Lead poisoning is another cause, as it disrupts heme synthesis and produces small, dysfunctional red blood cells. Thalassemias are inherited conditions that reduce globin chain production and characteristically cause marked microcytosis with only mild anemia. These traits are most frequently seen in individuals with Mediterranean, Middle Eastern, South Asian, Southeast Asian, or African ancestry due to genetic adaptations that once offered protection against malaria. Keeping these patterns in mind helps raise suspicion for thalassemia, especially when iron studies are normal, but microcytosis persists. Let's take a minute to review. Ferritin is the body's primary iron storage protein. It reflects the total iron stores, making it the earliest and most reliable marker of iron deficiency. Low ferritin is seen in iron deficiency anemia until proven otherwise. On the other hand, high ferritin is seen in iron overload or inflammation. Ferritin also rises as an acute phase reactant, so values may be falsely elevated in infection or chronic disease. The TIBC is the total iron binding capacity. It measures the body's capacity to bind iron, which indirectly reflects transferrin levels, the protein that transports iron. Transferrin never attaches to or sits inside the hemoglobin molecule. Instead, transferrin is a transport protein in the bloodstream. Its job is to carry iron through the blood and deliver it to the bone marrow, where hemoglobin is made, or the liver for storage as ferritin. Once transferrin drops iron off at developing red blood cells, the iron then becomes incorporated into the heme group inside hemoglobin, but transferrin itself stays outside the cell in the plasma. High TIBC is seen in iron deficiency anemia. The body makes more transferrin to search harder for iron. Low TIBC is seen in anemia of chronic disease, hemochromatosis, or malnutrition because the transferrin production decreases. Simple way to remember this? Ferritin equals the storage of iron, and it is low in iron deficiency. TIBC is the transferrin capacity, and it is high in iron deficiency because there is a high capacity to bind iron, which is low. Let's think this through. A microcytic anemia plus low ferritin and an elevated TIBC strongly suggests iron deficiency anemia. What is the most likely cause in a 27-year-old woman with otherwise normal labs? Chronic blood loss with heavy menstrual bleeding should be the first thing you think of. And in fact, the diagnosis is severe iron deficiency anemia, secondary to chronic heavy menstrual bleeding. The management should include oral iron replacement. This is first-line management. Evaluation for the cause of the heavy menses. Consideration of hormonal therapy and lifestyle guidance. For example, vitamin C is given to enhance absorption, and avoid taking iron with calcium. In symptomatic patients with a hemoglobin less than 8 and tachycardic, transfusion may be considered depending on clinical judgment and guidelines. Let's finish with the following takeaways. Microcytic anemia, I want you to think iron deficiency first. Ferritin is the earliest marker and the most reliable. Reproductive age women, menstruation is the leading source of chronic blood loss. Correct the anemia, but also identify and treat the underlying cause. If the exam gives you fatigue, tachycardia, pallor, and heavy periods, the answer is iron deficiency anemia until proven otherwise.